Hello, friends. Greetings. Today we have gathered here to discuss an important topic of iron deficiency and heart failure, dilemmas and therapeutic perspectives. So I, Dr. Omkar Swami, on behalf of MQ Pharmaceuticals Limited, welcome you all in this satellite symposium in HFAI Conference 2023. Iron deficiency with or without anemia is a frequently observed in a patients with heart failure. Uncorrected iron deficiency is associated with higher hospitalization and mortality in patients with acute and chronic heart failure. Hence, in addition to the anemia, diabetes, iron deficiency appears to be important comorbidity and treatment target in chronic heart failure. Today, we have gathered here to discuss the same in the patient of heart failure. Today, we will be discussing two important research studies of iron and heart failure. And these two important research studies will take us to important dynamics of heart failure and iron deficiency. And to take this session forward, it's my pride, privilege, and honor to welcome and introduce our moderator for the day, Dr. Uday Zadav, sir. Sir is a professor and faculty of MGM University of Health Sciences and also working as a senior cardiologist at Department of Cardiology in MGM New Bombay Hospital, Navi Mumbai. Sir has been a vice president of Heart Failure Association of India, and I feel that today in this symposium, sir will bring out a lot of practical as well as academic points pertaining to the heart failure. I have interacted multiple times and a close association with sir, and sir has been a mentor to me, and with the sir's guidance we have done a multiple program. Thank you very much, sir, being a part of this program as a moderator, and we look forward a lot of interesting discussion points and important pearls of wisdom with all the faculty. At the same time, it gives me a privilege to welcome our expert speaker for the day, Dr. Rajesh Badani, sir. Sir is a senior consultant interventional cardiologist at Aditya Birla Memorial Hospital, Pune. Sir will be discussing a very interesting study called a step-up study, which assess the frequencies of association of iron deficiency in patients of heart failure across the country. To best of our knowledge, this is the highest database of 3,400 patients of pan-India. Sir will be discussing today. Thank you very much, sir, being a part of this study. At the same time, I would like to welcome and introduce our expert speaker, Dr. R.K. Jain, sir. Sir is a senior consultant interventional cardiologist and director and head of the Department of Cardiology at KIMS Hospital, Secunderabad. Sir would be discussing an important study called as a PRIDE-HF study, which is a real-life study which assess the role of IV iron in the patients of heart failure. It's our privilege to have you, sir. Sir has been a principal investigator, and sir had conceptualized this study and motivated us to perform this study across the country. And sir was a principal investigator of this study, and along with Dr. Rajesh Badani, sir, and all other panelists who was a part of this PRIDE-HF study. So thank you very much, sir. Now, it gives me a privilege and honor to welcome our panelist, Dr. Sachin Patil, sir. Sir is a consultant interventional cardiologist at Sachin Super Specialty Clinic, Kolhapur. Sir has been a part of our PRIDE-HF study, and with the sir's participation in panel discussion, we look forward a lot of practical points about the iron deficiency and role of ferric carboxymaltose in management of heart failure. I also welcome our panelist for the day, Dr. R. Bhagirath, sir. Sir is a senior consultant cardiologist at Narayana Institute of Cardiac Sciences, Bangalore. Sir has been also a part of PRIDE-HF study. In fact, we have done this study in association with Narayana Rudayalaya CRO. So thank you very much, sir, being a part of this study. This would be our broad agenda. And as I mentioned, we will be discussing back-to-back two research studies followed by a panel discussion led by our moderator, Dr. Uday Zadav, sir. With this short brief, I would stop here and hand over this session to our moderator, Dr. Uday Zadav, sir, to take this session forward. Over to you, sir.
Thank you very much, Dr. Omkar Swami. It's been a pleasure once again to interact with you and the entire team from MCure Dr. Nanette Suarez. Uh, well, it's been a true privilege today. I'll tell you the simple reason is that I have had the opportunity to interact uh, with the ESC team in specific, who did the work on iron deficiency in heart failure. And I have been a coordinator for many programs when it comes to the context of iron deficiency and heart failure. But probably this is the first time, I must say, and therefore it will be a very humbling experience for me to have a data coming from our own faculty from across the country who will share with us the entire concepts of the prevalence of how they looked at iron deficiency in patients with heart failure. This is going to be extremely vital because whenever I have interacted with the ESC and at the ACC, the one thing that came up straightforward was, do you have a true data and a prospective study on the prevalence of iron deficiency in heart failure? So I must say, with all honesty, that this is what is important, not just having meetings and CMEs which talk about the concept, but to learn from our own colleagues and who have been principal investigators of the country. It's truly a very will be a great experience to learn from Dr. Rajesh Badani, Dr. Jain, Dr. Sachin Patil, my good friend Bhagirath Raghuraman. We will learn a lot about how we do it. Now, is this important? I was looking at a recent very good publication from the European Heart Journal that talked about iron deficiency in heart failure, and close to 60% of the patients have iron deficiency with coronary artery disease. Probably the prevalence could be higher in heart failure. And I am aware of a bit of a data that will be generated from our country. And I thought, are we going a little overboard? Do we really have iron deficiency to that extent? And to my surprise, yes. We also have a similar or even a little higher prevalence. And iron deficiency is extremely important as patients age, more in women, more in patients with CKD, more in patients with ischemic heart disease, for all sorts of reasons. The loss of iron, the phenomenon of atherogenesis itself causing a vascular congestion and increasing the hepcidin levels, and the erratic absorption given with the genotype that we see in Asian Indians, I guess this is a very important context. Now, does it really, just to set the tone, does it really make an impact on identifying it in an era where the 4 pillars of heart failure have already been established? Truly, it's an unmet need. You can pick up any study which is of relevance, let's say a DAPA-HF study. The incidence of iron deficiency in the DAPA-HF study, when you look at HFrEF, we don't have great data on HFpEF as on now, but in HFrEF at least, 43% and above had a iron deficiency. These are patients who are treated with dapagliflozin. So it's an important context. I welcome all my faculties, and without any further ado, let us learn from them, and then we'll have an interaction. Welcome, Dr. Rajesh Badani, Dr. Rajendra Kumar Jain, sir, Dr. Sachin Patil. Can we go ahead with our presentations, Dr. Onkar?
Yes, sir. We request Dr. Badani, sir, to start the session.
Is everybody able to see the slides?
Yes, sir.
Okay. Thank you, MCure. Thank you, Dr. Omkar, and thank you, Dr. Jadhav, for giving us this opportunity to discuss something. So I think even it is very exciting because this is the first time that some work that we have been able to do and generate, we'll probably be able to take expert opinion and maybe take this up further, that how we can really refine the treatment of HFrEF along with IV ion therapy. So I think the most important part is when we talk of iron deficiency in heart failure, the prevalence in ejection fraction below 15% is almost half of the people. With people with preserved ejection fraction is almost up to 60%. And coronary artery disease also, it's around 60%. And stroke and other issues, it's up to the tune of around 40%. Now, the most important thing is when you talk of outcome, people with heart failure with low EF and iron deficiency have increased mortality, increased hospitalization, decreased quality of life, and functional status is also affected. Now, heart failure with preserved ejection fraction, also you have an affection of quality of life as well as NYHA functional class is affected. CAD, it is associated with higher mortality and myocardial infarction, as well as functional status is affected in the patients who have stroke. Treatment response, when we talk of IVFCM, hospitalization, reduction of hospitalization, improvement in symptoms, improvement in quality of life, and functional capacity, all are increased. Whereas guideline recommendation, we have only iron to be given in patients with HFrEF, no role in HF with preserved ejection fraction or CAD or stroke. And direction of impact, no or inconclusive data in coronary artery disease. And obviously, improvement with IVFCM is probably seen in this group of patients. Now, introduction, we already know that heart failure is a leading global challenge representing a major cause of frequent hospitalization, morbidity, and mortality worldwide. Iron deficiency in heart failure carries significant health ramifications such as worsened exercise capacity, poor quality of life, and prognosis. With a 30 to 50% in stable chronic heart failure, iron deficiency is a major cause of anemia in these patients. And international guidelines on heart failure characterize iron deficiency as serum ferritin, if it is below 100 nanograms per ml, it's called absolute iron deficiency, or somebody who has normal ferritin in the tune of 100 to 299 nanograms, but a low transferrin saturation to below 20% is called functional iron deficiency. Now, when we talk of prevalence of iron deficiency and anemia in heart failure cohorts, the Indian data, which was probably of 150 patients, with NYHA class 1 being 10%, class 2 of 18%, prevalence was 76%, whereas the anemia prevalence was 51%. And when you look at all the international trials which are there, on an average, they are all above 50 to 70% is the prevalence iron deficiency, even across the globe. And Indian data obviously was lacking in terms of prevalence of iron deficiency in heart failure particularly. Now, when we talk of absolute iron deficiency, it is primarily because of decreased iron intake, decreased GIT absorption because of food-drug interactions. So the iron as well as the transferrin which is there in the circulation is decreased. That could also result because of GIT blood loss, reduction of the iron stores, and all these things result in reduction in the liver iron, bone marrow iron, as well as the spleen iron, and primarily resulting in a absolute iron deficiency. But when it comes to relative or functional iron deficiency, the combination of iron and transferrin, once it decreases, your decreased utilized iron is there, reticuloendothelial system bone marrow iron decreases, decreased iron turnover occurs, and results in decreased erythropoiesis. This all results in decreased iron delivery to the cells and tissues, particularly to skeletal muscle, which reduces exercise capacity, to cardiac muscle, reduction of the myocardial energetic efficiency, and results in mitochondrial dysfunction, where your ATP generation occurs, which is lesser, and that causes significant fatigue and tiredness in these patients. So we need to differentiate absolute from functional, but most important is hepcidin levels which are there, because increased hepcidin level because of the increased inflammation in IL cells straight away has got a negative impact in the iron as well as the transferrin reduction which occurs. Now, iron deficiency in heart failure, what are the clinical and prognostic significances? One is exercise intolerance, which results in reduced peak oxygen consumption, lower 6-minute walk test, decreased health-related quality of life according to the Minnesota questionnaire, increase long-term all-cause mortality in HFrEF and HFpEF, irrespective of presence of anemia. And in acute heart failure, hospitalized patients results in increased risk of rehospitalization, combined all-cause death, non-fatal cardiovascular or heart transplantation. So now 2021 guidelines for iron deficiency in heart failure suggests that it is recommended in all patients with heart failure be periodically screened for anemia and iron deficiency with a full blood count, ferritin, and transferrin saturation class 1C recommendation. IV iron with ferric carboxymaltose should be considered in symptomatic patients with EF below 45% and confirmed iron deficiency by ferritin below 100 or ferritin between 100 to 299 and transferrin saturation below 20% to alleviate heart failure symptoms, improve exercise capacity and quality of life, which is a class 2A level of recommendation A. And IV iron with FCM should be considered in symptomatic heart failure patient recently hospitalized for heart failure and EF below 50% and iron deficiency, accordingly with class of recommendation 2A and level of recommendation B. So class 1C recommendation to assess iron deficiency in heart failure patients itself is a very strong recommendation. But how frequently are we doing it and how common is iron deficiency is another challenge which is there. Now let's talk about the diagnostic algorithm of iron deficiency in heart failure. As you all know, iron deficiency is identified by low ferritin or normal ferritin with low TSAT. Stable heart failure with iron deficiency. If the EF is more than 45, there is no role or no evidence of giving peroxycarboxymaltose, but somebody whose EF is below 40-45%, NYHA class 1 and class 4 have no evidence, but if it's class 2 to 3, you look at HB, if it is 12, below 12 or below 13, below 12 in males and below 13 in below 13 in males and below 12 in women, you exclude secondary causes, correct other causes like folate, B12 and hypothyroidism. Then if your HB is between 13 to 15, exclude active infection, malignancy and hypersensitivity. And then probably give IV ferric carboxymaltose in this group of patients. Now, practical guidance, if somebody has got patients with heart failure, suspected chronic heart failure, step 1 is check iron deficiency. Second is check anemia. If it is not there, or if it is there, rule out iron deficiency treatment considered in patients with symptomatic LVEF of less than 45% with iron deficiency, hospitalized for acute heart failure with iron deficiency, and symptomatic recently hospitalized for heart failure and with the EF of below 50% plus iron deficiency. Note that if HB is above 15, do not administer IV iron. When we talk of dosage consideration, there is a body weight as well as the amount of hemoglobin, but on an average, we have used around 1000 mg of this IV peroxycarboxymaltose, and there is a table which probably we can go through it later. Step 4 is next scheduled visit, which is preferably after 3 months, check for ferritin plus TSAT. And the last but not the least, check ferritin TSAT at least 1 to 2 times per year, on an average once in 6 months to 12 years, or if the change in clinical picture or hemoglobin decrease occurs. So let's come to the study rationale. The present study was conducted with the objective of estimating the true prevalence of iron deficiency in Indian patients with heart failure that will enhance our understanding of the true burden of this disease in India. Primary objective is to estimate the frequency of absolute and functional iron deficiency in patients with known cases of heart failure in India. And secondary objective is to assess gender and age association of absolute and functional iron deficiency in patients with known cases of heart failure in India. Methodology: study population more than 18 years of age who visited the heart failure clinic and provided consent for the use of their anonymized data in the future. 3,400 patients from various clinics across India were included. It's a retrospective multi-center observational data collection design. And the study duration was 24th March 2021 to 31st March 2022. The study flow was 586 heart camps were conducted, 373 centers, patient with heart failure and iron deficiency visiting heart failure clinics, informed consents taken, demographic characteristic and hematological parameters were taken into account. The study was approved by the Independent Ethics Committee, Dhanashri Hospital, Pune. The study was registered with the Clinical Trial Registry of India, CTRI, with a registration number of so and so. The results: 3,400 patients, 41.9 were males and 58.1 were females. The mean age was 45.39 plus minus 17.808 years. Age group below 50 was 63.4. 51 to 60 was 15.3, and above 70 was 21.3%. Frequency of patient absolute iron deficiency was in 68%, functional in 7%, and no iron deficiency was seen in 25% of the patients. Gender-wise prevalence, if you see, males are in the blue column and females are in the red. If you see, females were 1599 and males were 702, the absolute deficiency. Functional, males were higher than the females, whereas no iron deficiency, higher number of males versus lesser number of females. Now, age-wise prevalence, 21 to 30 was 18%, 31 to 40, 14.85, and 13.29, 41 to 50% age group, whereas functional, it was more of seen in 57 and 63, that was 1.68 and 1.85 between 51 to 70. So as compared to the absolute iron deficiency, which was common in 20 to 50 years, functional was predominantly common in 50 to 70 years. And no iron deficiency was probably seen in the 40 to 60 year age group. To find the findings of our study emphasize a remarkably high frequency of iron deficiency in Indian heart failure patients. To the best of our knowledge, this is the first study in the recent past evaluating the frequency of iron deficiency across a pan-Indian population of ambulatory heart failure patients with uniform diagnostic criteria. What are the strengths? First multi-centric study evaluating frequency of iron deficiency across pan-India, sample size 3,400 patients, central standard laboratory used. Limitation was that it was a retrospective study design and we could not retrieve the data on NYHA class EF or the type of heart failure. So in conclusion, present study highlights the frequency of absolute iron deficiency of 68%, functional iron deficiency of 7.4 in Indian patients, and evaluation and management of iron deficiency is promptly needed to improve the heart failure outcomes. So the take-home messages are: present study highlights a remarkable high frequency of iron deficiency, 68% absolute and 7% functional. And this was pan-India in ambulatory heart failure patients. Evaluation and management needs prompt treatment to improve heart failure outcomes, and heart failure patients should be routinely screened for iron deficiency by getting a complete iron profile, including ferritin as well as transferrin saturations. Thank you very much for a patient hearing.
Thank you, Dr. Rajesh, for bringing out the data from STEP UP. And let's look at the therapeutic part of intravenous FCM. Professor Dr. Rajendra Kumar Jain will now share his thoughts and his experience from the clinical study. Thank you.
Thank you, sir. Thank you for introduction, and thanks MQ to give me an opportunity today. So I'll share my screen. My slides are visible?
Yes, it's loading, sir. Yes, now need to full mode. That's it.
Okay. So it is a very interesting thought. As Dr. Jadhav said, we always wanted Indian data, and I keep on asking MQ to do this data. With a lot of difficulty, I could convince them. About 5-6 meetings, and then everybody came on board, and I guided them. It was one of my pet projects. In fact, I wanted a bigger chunk of patients, but we could get this many number of patients. So this is a prospective observational study to assess effectiveness and safety of intravenous ferric carboxyl maltose 1000 milligrams in a patients of chronic heart failure with iron deficiency. And this is named as a Pride Heart of Studies. Along with me, Dr. Rajesh Badani, Dr. Sachin Patel, and Bhagirath Raghuraman were part of the study. And the sponsor is MQ Pharmaceuticals from Pune. As Dr. Rajesh has told very clearly what is functional deficiency, what is absolute deficiency. I'll just briefly go through the important points. The iron deficiency leads to anemia in many patients with chronic inflammatory conditions. And in heart failure, iron deficiency adversely affects exercise capacity, quality of life, independently of anemia, and predicts worse outcomes, include mortality. And ferric carboxymaltose is used for rapid and high dose replenishment of depleted iron stores. In heart failure patients, the effectiveness and safety of IV ferric carboxymaltose for iron depletion has been demonstrated, while oral supplementation had failed to replete iron levels in such patients. So the iron deficiency in heart failure, the causes and consequences are, whenever there's a heart failure, there's inflammation, and this inflammation causes increased hepcidin activity, and this hepcidin activity causes functional and reduced mobilization, and this causes iron deficiency. And the second mechanism, reduced iron absorption, blood loss, and medication, they also can cause iron deficiency. All these things, iron deficiency, you can call mitochondrial abnormalities, decreased cellular oxygen storage, impaired cellular energy release, impaired erythropoiesis, impaired reaction of oxygen-specific metabolism. And this again results in reduced aerobic capacity, reduced endurance capacity, fatigue, impaired quality of life, and worsening prognosis. So basically, in heart failure, the inflammation and the blood loss and medications can lead to iron deficiency anemia. So the pathophysiology of iron deficiency in heart failure is summarized in this slide again. Patient with heart failure with reduced ejection fraction, inflammation, the renin-angiotensin aldosterone overactivity, and also sympathetic nervous overactivity. This causes inhibition of transferrin receptor protein TFRI required for import of iron into cells. And this iron deficiency lead to decreased cellular oxygen storing and carrying capacity, impaired cellular energy release, 6-hour cycle, impaired cellular reactive oxygen species metabolism. And this results in reduced exercise capacity, fatigue, worsening heart failure prognosis, and increased hospitalization. The last two are very important in the prognosis of and pathogenesis of heart failure. The screening and treatment of iron deficiency across the heart failure with reduced ejection fraction is a continuous process. As earlier speakers already has highlighted that it has to be periodically screened for anemia and iron deficiency 1 to 2 times per year and treat iron deficiency as required. Ferric carboxymaltose should be considered in symptomatic patient whenever the LV ejection fraction of less than 45% and iron deficiency anemia is there. So during hospitalization, should be considered in patient all hospitalization, pick up iron deficiency anemia and treat the iron deficiency anemia. Also, patient post hospitalization and or who are recently hospitalized, there's another subset of patient where the patient has to be checked for iron deficiency anemia and the treatment has to be done. And the next admission again during hospital administration and post hospitalization also, we should evaluate, check these patients for iron deficiency and treat the iron deficiency with ferric carboxymaltose. The study rationale was the real world study was conducted to expand the understanding, the clinical effectiveness and safety of ferric carboxymaltose in Indian patients of stable chronic heart failure with iron deficiency. The primary objective was to evaluate the effectiveness of treatment with IV FCM in patients with chronic heart failure with iron deficiency by assessing improvement symptoms at week 12. Secondary objectives to evaluate the effectiveness of treatment by assessing quality of life at week 12, to evaluate safety of IV FCM at week 12, to evaluate the improvement in the hematological indexes as week 12, to evaluate the improvement in symptoms, quality of life, and hematological indices at week 4. The study population was stable chronic heart failure patient with iron deficiency, planned to treat with injection ferric carboxymaltose as a part of routine clinical care. The study drug was injection ferric carboxymaltose, ferrium 1K by Emcure. Sample size was 98 subjects from 4 sites were included in the study. The study design is prospective, multi-center, non-interventional observational study. The study duration was 3 months, March 2021 to August 2022. The inclusion criteria was Indian adult with more than 18 years of age, patients of either gender, stable symptomatic ambulatory patient diagnosed with chronic heart failure, NYHA class 2 to class 3, and patient have iron deficiency. Iron deficiency was diagnosed when the serum ferritin level is less than 100 micrograms per liter or is between 100 to 299 micrograms per liter, and the transferrin saturation TSAT is less than 20%. Patient ready to give informed consent for participation of the study was a must. Exclusion criteria, the patients were not willing to give sign informed consent form and provide medical data. hypersensitive to ferric carboxy maltose injection, participation in any clinical trial in the last 3 months, treatment with IV iron preparation within 4 weeks prior to study enrollment, and the condition that in the point of opinion of investigator does not justify the patient inclusion in the study. The study flow was the patient with heart failure with iron deficient anemia planned to be started with injection FCM. Informed consent was taken. The data collection, demographic characteristics, disease profile, and medication history was collected. The variables at baseline, week 4 and week 12 were corrected. The lab tests were hemoglobin, serum ferritin, TSAT and TABC level, MCV, MCSC, and MCV were collected. NYHA class was documented, ejection fraction was calculated. The self-reported physician global assessment score was collected. Adverse event with focus on hospitalization and death were also collected. So these were the parameters. Treatment details at baseline, week 4 and week 12 were collected. NYHA class was noted at baseline, week 4 and week 12. 2D echographic findings at baseline, week 4 and week 12 was collected. Serum ferritin, TSAT, TABC, hemoglobin, MCH, MCHC, and MCV was collected. All the 3 visits. Self-reported physician global assessment score was collected at week 4 and week 12. Adverse event was collected at week 4 and week 12. The study procedure studies were, the subject was found to be eligible as confirmed by the inclusion exclusion criteria by the principal investigator or co-investigator or enrolled into the study. Data was collected by the investigator as per case report forms. Patient demographic characteristic, disease profile, significant medical history, treatment details, and concomitant medical details were recorded. All the subjects were followed up for 12 weeks and details of assessments were mentioned under study visit assessment. Data collected was analyzed using a suitable statistical methods. The ethics committee involved were from the Narayana Medical Ethics Committee, which we got approval in January 2021. Aster Aadhar Ethics Committee, we got approval in 16 February 2021. KIMS Ethics Committee, we got approval in 2nd April 2021. Aditya Birla Memorial Hospital Ethics Committee, we got approval on 5th October 2021. The study was registered with CTRI 2021-2031308 dated 16/2/2021. In a clinical trial registry, India data was registered. The study flow diagram, number of screen patients was 450. The not eligible patients were 352, not willing were 0. Number enrolled were 98. Number of subjected completed 12 weeks follow-up was 95. Number lost to follow-up was 3 patients. The baseline demographic age was in the mean of 61. 58% of the patients were male. Heart failure with reduced ejection fraction 79% of the patient. And heart failure with preserved ejection fraction was 20% of the patient. Etiology of heart failure is a myocardial infarction in 22%, hypertension in 19%, atrial fibrillation in 2%, valvular heart disease in 6.1%, cardiomyopathy in 31%, and others in 18%. Association of comorbid condition, diabetes was present in 60% of the patient, hypertension was present in 66% of the patient, post-MI 19.4%, stroke 6.1%, ischemic heart disease 31%, dyslipidemia 17%, renal failure was present in 5% of the patient. The improvement of NYHA class from baseline to week 12, the 0 number of patients were included in class 1. From class 2, 45% at 43% in class 2 at baseline, and 56 in class 3 at baseline. At week 4, number of patients who came to class 1 is 10%. From 43, class 2, 68% of the patient, and from class 3, it was 21% patients. So more number of patients came to class 2 from class 3. And at week 12, again, number of patients in class 1 was higher, that is 30.5%. Number of patients in class 2 was 61%, and number of patients in class 3 was 8.4%. So from 56% baseline NYHA class 3 patient, it reduced to 8.4%. So there is a significant improvement in NYHA class in this group of patients who had iron ferric carboxy maltose infusion in patient with heart failure with reduced ejection fraction. And when the serum ferritin levels increase at the baseline from 54 to 226, and transference TSAT saturation also improved from 11 to 24% at 12 weeks. And total iron binding capacity also, there was no change in this. There was total iron binding capacity, it also improved from. And the next, the self-reported patient global assessment at week 4 and week 12. So there was a much improvement. Patient was 33% at week 12, moderately improved at 38% and little improvement was a very little number of patients was there, and unchanged or little worse for patient only 1.1% patient. The discussion was the findings from our study emphasize on the role of IV ferric carboxymaltose for iron deficiency in Indian heart failure patient. Real world studies on FCM are largely lacking, especially from India. To our knowledge, this is the first multicentric real world experience evaluating the effectiveness and safety of IV FCM across all types of heart failure in large population of Indian patients. The study provided evidence for the clinical study of IV FCM for the short-term improvement in quality of life NYHA class. Strength and limitation. The strengths are first real-world multicentric Indian study, systemic evaluation done from baseline to week 12. Limitation, it a retrospective study design, 2D echo 6-minute walks test parameters were not assessed and a small sample size. Conclusion, the present study highlights treatment with IV FCM significantly improves NYHA class, quality of life, and self-reported patient global assessment. IV FCM was well tolerated. Coming to take-home messages, the study provides real-world evidence of FCM efficiently and safely correcting iron deficiency in chronic heart failure patient. FCM leads to improvement in NYHA class, serum ferritin, and TSAT levels. Patient also reported improvement in self-reported patient global assessment at the end of 12 weeks. No adverse event, hospitalization, or death were reported during the study period. Thank you very much.
Thank you, Professor Dr. Rajendra Kumar Jain.
Thank you.
Well, we must congratulate MQR in coming out with this specific study. It's a therapeutic study, and as we say, this is the proof of the whole concept, how you put IVFCF in use for Indian patients. And the STEP study, which Dr. Rajesh Badani shared with us, talking about the epidemiology and prevalence. So this is the true first data that I am aware of what actually IVFCM can do, both in the quality of care of the patients, the change in the NYHA class, and what potential impact it can make on patients with primarily of HFrEF and probably some level the small number of patients with HFpEF. So let me, Dr. Nayanet, would you want to come in with some points before we ask other experts, Bhagirath and Dr. Sachin Patil?
Sir, you can take it forward, sir. We know no specific point.
Okay, thank you. So, well, let us invite comments from Bhagirath first. Bhagirath, this is exciting, right? Congratulations, you have been part of this data from Narayan Hrudayalaya, and I'm sure this is something which we were awaiting for a long time in our heart failure meeting, that somebody should tell us what's exactly happening to the to the prevalence and second to the patient. So please, your comments.
Yes. Audible now?
Yes, sir.
Yes. So the first thing is that it just went through the ethics committee without a question, because I think the entire team of the ethics committee was very impressed that this would be the first real world study data on this particular aspect. So that itself, really energized us to proceed further. And we've heard a lot about the therapeutic value of correcting anemia and heart failure. We are one of the largest centers in the country treating heart failure. And once we got into this trial, I think we had excellent data. As you can see in the data that was just presented, we had a significant improvement in the NYHA class as well as the symptomatic status of most of our patients. There were no dropouts, no intolerance, no side effects. So I think this further reinforces the view that we should screen all heart failure patients for anemia and correct it as soon as it's possible, because along with the 4 pillars of the guideline-directed medical management, this is an important component in the management of heart failure.
Thank you. Dr. Omkar, do we have Dr. Sachin on board? Has he joined us?
Yes, Dr. Sachin.
Very nice. Dr. Sachin Patil, congratulations for being a part of this study. Really, This is a great data. Your comments and thoughts.
Yes, actually means maybe I'm teaching in a medical college and a being theoretical person. I was a bit aware that okay, FCM is available and it is very much indicated. But this study just reinforced my belief into that scientific content when we see actually that the patients are really, getting the benefit of it and they have really improved by the class. As you know, the my prior person also said, ethics committee straightway was approved because it's a post marketing as good as surveillance kind of thing where the product is established. We just have to study in Indian subsets. But for me, it was interesting whether it whatever has been claimed, can we really see it? And that was the pleasant finding that most of the patients really got the benefit of it. In fact, my center was one of the center where we recruited even the heart failure with preserved ejection fraction also. That okay, let us test all the hypotheses, really it works or not. Even maybe I remember distinctly 3 or 4 patients who were having a HB of 11.8, 12.5, but the fitting into the rest of the things, even there I could notice that there is a improvement in the symptom class. So whatever that guideline says to A or may be beneficial, but if that person fits into it, I really feel that it gets the benefit of it. And I was using it even before also, but it just reinforced my belief into that molecule, and we have been using it quite a bit. The little bit hindrance I faced during this study was because just the COVID was passed by, so a lot of ferritin values were coming high. Though I know that this patient is real iron deficient and real thing that he needs it, everything was fitting except that ferritin. So a lot of screening went in, but many patients could not qualify it because I felt that it was a false elevation of ferritin because of the inflammatory status which patients were having post COVID. So even those patients later on after the study, I gave them the FCM. And really, even in that work, because clinically my assessment was very right that yes, they deserve it. But I think we have to, for trials, we have to go by the guidelines and the trials, while off-label is always off-label. But it's a fantastic molecule. And I must congratulate MCure that I have been using a fair inject for a quite long time, and I didn't see any much differences in the, as far as the side effect profile or something, or any of the adverse effect. Even the efficacy is quite similar. So in my mind, there is no hesitation that which company I'm using. I'm very happy with Ferium Monthly.
Right. So I guess that because you have mentioned this, let's come up with this. I think so Dr. Rajendra Kumar may probably want to comment on it. So, I mean, we talked about ferritin and FCM and how do we fit in. So is this not an issue to some extent, of course, that, if you use serum ferritin as a marker to study iron deficiency, heart failure by itself is a chronic inflammatory state. So you expect more of hepcidin secretion, right? And therefore you will have a ferritin value which will be spuriously on the higher side. And that has caused a question also whether or not you should incorporate a serum iron in the studies of anemia of heart failure. Mind you, that does not underrate the importance of ferritin, because the very proof that ferroxycarboxymaltose, ferric carboxymaltose, FCM in all these patient subsets of ferritin less than 100 or 100 to 290, for example, all have responded very well in these studies. But well, that brings us to the principal question. The reason is the 3 parameters which we commonly use in clinical practice, as you mentioned, the ferritin and the TSAT levels and the iron binding capacity. Most of them actually have come from nephrology reviews and nephrology trials. I mean, we haven't really had cardiovascular trials for that, because it's different when you talk of heart failure, you talk of kidney disease. And it probably may not very correctly reflect upon the bone marrow histology. I'm putting this point of contention at this level because even if we say that, and even if you use ferritin as a marker, FCM has proved its worth, it's improved that. But just as a thought, because clinicians are going to ask us, Professor Dr. Rajendra Kumar, all the faculties, can we also incorporate now serum iron as a part of FCM's responses? Your comments, please.
Yeah, I think what we did in the study, we took all the parameters. In fact, it is not only when we order iron profile, we routinely do in a routine clinical practice. It is not only ferritin and DABC. We always check the iron levels also. We check all these things. And then only those patients would fit into the criteria we have given injection FCM.
Bhagirath, your comments?
In fact, if you see the latest article on this IV iron, it says that apart from looking at all the parameters, you can also measure soluble transferrin levels as well as hepcidin levels. These add a real robust value to how to assess whether the patient is really iron deficient. So this will further reinforce which patient truly deserves iron. And that way we can more or less filter out those who are the outliers. Like Dr. Sachin said that, you have some patients in the gray zone. Do you give, you don't give, do they fit in all the criteria? So when you add this also, it adds great value to identifying the real patient who will benefit from iron therapy.
Absolutely. I think it makes sense to have the transferrin receptors on board. Only thing is, it's not easy and practical to do that. And therefore, we need to use all the markers. You can't call them surrogate, they're good markers. Even for that matter, even ferritin is a reasonably good marker. Dr. Rajesh Badani,
Yes.
I looked at the prevalence data, and this is the first time I'm looking at it. Mind you, I haven't seen your slides before any time. The 68 point, close to 68% iron deficiency that we found in the clinical study, which you sort of pioneered. The incidence is quite a bit in the young people. It's between 20 and 45, and Omkar can correct me on that. And then I looked at the relative deficiency, a little more in the elderly patients. Now, when you look at absolute iron deficiency in the younger people, and you look at the text and the literature, even in Europe, or for that matter in the United States, most of these patients have been elderly. And we do not pay attention to the younger population. See, we have in India our own thought processes. It's elders who are sick. It's elders who have all the reasons to get iron deficiency as a pathophysiology, and therefore we want to target it. It's quite interesting, right? That in our heart failure segment, you found younger patients.
Sir, it's interesting, but at the same time, I think if you look at all the registry which is there, particularly our heart failure registries, we have three of them primarily: the Medanta heart failure, the Trivandrum heart failure, as well as now the latest National Council of Heart Failure registry, which is there. Amongst them, the interesting part is the Medanta had a very younger population. Their average age was around, if I am not mistaken, 45 to 50 years is what it is. And predominantly, it is more of an ischemic and a dilated cardiomyopathy predominantly. Secondly, we see a lot in our electrophysiology crowd also, we see a lot of women coming with asymptomatic idiopathic dilated cardiomyopathy, and it exactly correlates with the iron deficiency in women in the younger population being higher as compared to the men. So I believe, as you rightly said, this becomes very relevant. We are talking of 4 pillars, but if you are having a younger patient with a HFrEF, it makes all the more this point very strong that you should evaluate for iron deficiency in them. And these subset, if you're able to correct them, that really improves. As of now, we have data only about quality of life and symptom reduction. It will be very difficult to evaluate a data which shows event reduction, because you already have 4 pillars on board. You have a CRT and ICD and other things in patients who are LBBB and criteria into that. So I believe this, from a quality of life and symptom improvement status, is a very important thing. The younger people, you should evaluate if you have HFrEF. And I think, being cardiologists, we are somehow diverted by the 4 pillars, and somehow it just doesn't strike your mind that you should look out for the iron studies in these group of patients. But somehow a consensus, if we are able to form more and more from an Indian perspective, particularly younger ones below 50 years, that would add to the impact that a drug like this can produce in the quality of life and improvement of 6-minute walk distance as well. Because those are, most of them are very active patients, working class patients, and there even a walking distance improvement can really have a lot of impact on their quality of life scores. That's what I do.
Well said, well said. I think you have put the right emphasis for clinicians all over the country, not just clinicians, even hospitals for that matter. We we will take up this sort of important inferences from your study so that the hospitals and universities are benefited, right? I mean, we'll start looking at patients using this information a little more carefully. Uh, well, as I come to this point, because I would like your opinion on this. So we always have this question, well, is this all translating into outcome data? Will the primary events be prevented? So I just wanted to just mention that in the DEPA HF, which included dapagliflozin for correction of heart failure, the rate of primary outcome, if I correctly remember, was about 16 per 100% year in those patients who are iron deficient compared to close to, what was that? Close to 10.4 per 100 persons per year. So there is a definite importance in terms of even when you use the heart failure pillars of therapy and you correct the iron, you will have certainly have better primary outcomes. So as you have done both these studies, let me have comments from all four of you, starting with Bhagirath, and then we can have Professor Rajendra Kumar and Sachin Patil and Rajesh Badami. Do you think this should now further encourage for outcome study in India? And
Yes.
what are your thoughts?
Definitely, I think that the initial data that was just presented is very promising, and you have a significant improvement in the quality of life, in the NYHA status of the patients. And these patients we have on follow-up, we see them regularly, and all of them are doing well. One point that I must emphasize here is the iron therapy is a one-time solution, whereas if you see the 4 pillars, you need to take them every day. Whereas here, you just identify the subset and you can correct it, either 500 milligram for those less than 35, or those in the 35 to 70 kg group, 1000 milligram, and then you have it corrected and sorted out. So that's one out of the way, and then you focus on the other guideline directed medical management. So I think this has come in at the right time in our management of heart failure, and we are seeing very promising results, and this further reinforces that we will be looking for the iron deficiency in all patients in our heart failure clinic, and continue the therapy as per the guidelines as of now.
Professor Dr. Rajendra Kumar, your comments.
Yeah, it's a very nice concept, but only thing is MQR has to come and sponsor the study. I think they have some hesitation in doing this outcome study. I kept on telling that the number we wanted in PRIDEF is a massive number. I saw at least 400 to 500. That was what my aim when I told him the concept. We're more than willing to take the responsibility of doing the study. It's not a problem. We have enough number of patients. We have enough number of heart failure patients. And they're willing to take the test and do a follow-up. That's absolutely not an issue at all. The only issue is somebody has to come forward to keep all of us together, and one CRO like Narayanazala is, they can do it. And one sponsor comes, it can be taken. But it's a very good idea. It will be a fantastic idea. Only thing is, it all depends on MQ's further going into this molecule. The only one challenge I still face is little challenges, especially most of them can afford this iron profile, but that is becoming a little expensive. In fact, our hospital, the iron profile is more expensive than the Ferry 1K. So that's a real challenge in our hospital. That's what we face. So some of the patients, we get them outside done who can't afford. When we tell them that when you come back next time follow up, you get an iron profile done from outside, not on the same day, so that they come with iron profile, and then how we treat. That's a small help we're able to do to these heart failure patients who are on chronic medication. Now at least The ARNI medication, the cost has come down. So it is really, really boon for these patients, heart failure. Otherwise, the cost of ARNI and the cost of DAPA, which has also come down, and the cost of Ferium, cost of investigation, all these things are an issue.
I guess it's doable, this study with Dr. Omkar at the helm of affairs. It's quite possible, I guess. One can always, his team can always look forward with your enthusiasm, I think. That's important. Our enthusiasm is also equally important, not just the pharmaceutical industry to help us out in the study. So I think well said. Dr. Sachin Patil and then Dr. Rajesh, your comments, please.
Yeah, so the concept is very attractive because the 4 pillars has to go on and a lot of titration things going on and goes on. While this is a one-time treatment, at least it serves for 3-4 months. That's what my experience is. Though sometimes I do repeat their samples after 6 months to are they that has been corrected, the iron deficiency. Though most of the time clinician wants to go by the HB, but sometimes I do go into the iron profile also, because in our place it's not that costly. Definitely the cost is less than the FCM. So I do get it repeat. And if there is still a deficiency, I do correct it with the 500 or 1000 depending on the magnitude. And the patients are done. So we achieve a good benefit at one shot. Second thing is, I must have given a lot of FCM, but I haven't yet encountered allergic reaction except one which was significant and one which was a minor, and both were out of the study. So with Ferium 1K, I have never encountered, but with the other molecule, I did. So I see a good effective therapy at very minimal side effect level and one-time therapy. So concept is attractive. Now the second issue was whether there should be an outcome trial to prove the hard endpoints or this, then it becomes a difficult. The sample has to be very large and the duration has to be very large. Plus, we'll have to keep on following also, whether that has been corrected adequately or not, all the parameters. So that will be a bit exhaustive, but yes, it will be doable. And if it is does and shows, it will be a landmark thing. Definitely, it will be a landmark thing. So as Dr. R.K. Jain also said, we have a lot of heart failure patients and we are enthusiastic about the science. So if someone takes up, we are in for it.
Right. Thank you. Before Dr. Rajesh adds, let me ask also Dr. Rajesh, common question, right? If patients cannot afford the profiles and then you are recommending this for therapy of heart failure, how long you will continue the therapy? 2 years, 3 years? How frequent are your injections?
Okay, so I'll start with that. I think this has been a pretty long discussion about duration, but what I think across the consensus field that even if you are able to do it 6 monthly or even yearly, I would say, which is more practical, once in a year should be good enough as far as iron stores are concerned. So 1 yearly evaluation of your patient, giving them 500 or 1000 depending on their profiles, still practical. But I have 2 points as compared to what we are talking. Number one is, if we have done so much effort to get a fantastic result by a quality of life scoring as far as this is concerned, the most important part is that if you look at all the data about all your 4 drug therapy which is there, at the best of best centers, not more than 15% receive more than 4 pillars. I recently have had 100 of my OPD patients being evaluated as a part of the audit. And even in my OPD, my number goes to 38% being on all 4, 32% or 35% being on 3 out of the 4 pillars. So today, if it has a class 2A recommendation for an iron evaluation in most of our HFrEF patients, I think it becomes very imperative that if we are more number of investigators coming on board, and it's not the hard endpoint proving superiority, even if you show a non-inferiority or reduction of hospitalization, I think this drug or this study would be one of the largest studies which probably can really prove that at least in a Southeast Asian country like ours where iron deficiency is common, if I'm able to give a drug that has to be given once in a year, which is not costing very much, and it reduces my hospitalization and may have a little impact on my mortality benefit, I would say that if 1 pillar India can give it to abroad, amongst the 4 pillars, you, I think, achieved a lot. I agree there will be a lot of efforts which will go into it, but I practically feel it is doable. And the people who believe that it has an impact onto survival, that to just a drug like IV iron can do such an impact, after this study, I think it is a landmark thing which is there. I believe that's what my thoughts are.
All right. So here is my little thinking on it also, that the outcomes have already been self-implicated in most of the major studies. I mean, you can look at MPART, DEPA-HF, if you take SGLT2, most of the heart failure registries. So do you really have to redo a study to prove the outcomes? I do not see how it will differ in India, why it should not benefit the Indian patients of heart failure. I strongly feel that it will have the same benefit. Probably the only question is whether besides the pillars of heart failure, where you have reasons to exclude one or the other, or you have reasons, and these are not science-based, these are patient requirement based, or the difficulties that the patients have to optimize the dose of those heart failure. Whether beyond this addition of IVFCM, because I believe IVFCM is one of the easiest therapy to give. You give and you are done with it. Now, you may want to give it 1 year. The highest enthusiasm I find is from Europeans is every 3 months. Indians feel that it cannot be less than 2 times a year, at least give 2 times a year, if not 3 months. Well, that's the only aspect which should be interestingly looked at. Otherwise, I see, as you have all shown in your data of quality of life, it's certainly going to make a difference. I think the outcomes may probably be equally good and certainly non-inferior to most of the global outcomes data. So that's just a comment. I think we are almost at the time, and then I'll request Dr. Onkar Swami to put in his words, and finally the...
So, sir, thank you very much bringing out the important discussion points of Step Up Camp as well as Pride HF study. I'm fully aware, sir, confidence lies in the number of the sample size and the duration of which we are looking forward. So we will always certainly look forward. This is a first step to understand how and maybe how it happens and how it behaves in an Indian patient. But as Sir Jadhav sir has already mentioned, what results we have observed in the published literature, we not be feeling something different from that. So we expect there is a change in a quality of life, but almost we requires larger sample size study to understand more benefit and maybe more subgroups. That also we keep into the mind, but I feel, sir, the data of Pride HF is a good to understand the quality of life, in particularly in Indian patient, and also the comorbidities, and importantly, 20% patients were preserved ejection fraction also. So we'll look forward, sir, whatever your suggestions look forward. At the same time, I would like to extend my deep gratitude to all of our principal investigator, but the R.K. Jain sir to begin with, who has conceptualized this study, Dr. Rajesh Badani sir, Dr. Sachin Patil sir, and most importantly, Dr. Bhagirath sir, and the CRO of Narayan Hrudayalaya, to which we have worked for last 1 year. COVID was a difficult time during, and because of the high ferritin, we have screened almost 450 patients, but ultimately end up with recruiting only 100 patients. So that was the big limitation that we faced, just because study was during and just after the COVID time. But I think, sir, these results are clinically relevant to larger population. And thank you very much, sir, our moderator, Dr. Uday Jadhav, sir, bringing out some important discussion points, which is quite relevant to most of the people who are watching this symposium. With that note, we'll stop here. Thank you very much for joining us, and we look forward for further interactions as well. Thank you very much, sir.
Thank you, sir. Thank you, sir.
Thank you.
Thank you so much,
very
sir.
much. And
Thank
on
you so
behalf
much,
of
sir.
all our colleagues